Assalamu alaikum wa rahmatullah wa barakatuh. Bismillah ar-Rahman ar-Rahim. We start with the sixth lecture of inflammation. And the objectives of this lecture are to understand the causes, morphologic patterns, and possible cells, minor cells of chronic inflammation, and granulomatous inflammation. Chronic inflammation is defined as inflammation of prolonged duration. It takes weeks, months, or years. In contrast with acute inflammation, which is distinguished by vascular changes, inflammatory exudate or edema formation, and a predominantly neutrophilic infiltrate. Chronic inflammation is characterized by a different set of reactions, which are the following histologic features. First, chronic inflammatory cell infiltration of the tissue, including lymphocytes, macrophages, and plasma cells, which are mononuclear cells. Means these chronic inflammatory cells have single nuclei. So, there is a polymorphic infiltrate in chronic inflammation with multiple or many cell types, while in acute inflammation is monomorphic infiltrate, only one type of cell, which is neutrophil. Second, tissue damage and destruction, which is induced by the products of inflammatory cells. Third, healing and repair by fibrosis. In chronic inflammation, the healing is usually by fibrosis and scar formation. So, there is new blood vessels proliferation by process of angiogenesis and fibrosis with scar formation. Chronic inflammation is more productive in nature, means production of granulation tissue, which is tissue of healing. Then granulation tissue matures into fibrous tissue. So, chronic inflammation is not exudative in nature, and there is no inflammatory exudate formation in chronic inflammation. Fifth, there may be foci of suppuration, as in chronic abscess. So, abscess is a feature of acute inflammation and chronic inflammation. And the last feature is granuloma formation, which is a feature of inflammation that will be discussed later on. How does chronic inflammation arise? Means the origin of chronic inflammation. Chronic inflammation may arise either from the progression of acute inflammation into chronic inflammation due to the persistence of the causative agent, or chronic inflammation may develop or may arise ab initio or de novo, means from the start is chronic inflammation, which is the most common. Acute inflammation may progress to chronic inflammation due to the persistence of the causative agents, as in the following conditions. First, inadequate drainage of abscess, example, bone abscess or empyema of the pleura. Second, presence of the foreign body in the tissue, such as pieces of glass, cloth, or dirt, as in the road traffic accident, or presence of the non-absorbable suture material after surgical operation. And third, repeated attack of acute inflammation, as in the presence of gallstone. The first attack of acute cholecystitis, then a repeated attack of inflammation due to the presence of the gallstone, leading to the chronic cystitis. Chronic inflammation ab initio or de novo. It starts as chronic inflammation from the beginning, as in the following settings. First, persistent intracellular infections such as viral infections, tuberculosis, syphilis, parasitic and fungal infections. All are regarded as chronic inflammation. Second, immune-mediated inflammatory diseases, which include A. Autoimmune diseases. All autoimmune diseases are chronic inflammatory diseases in which there is a formation of autoantibodies against on-tissue antigens, such as rheumatoid arthritis, systemic lupus erythematosus or SLE, psoriasis, and ulcerative colitis, which is a chronic inflammatory bowel disease. B. Allergic diseases, in which there is immune response against environmental substances, as in the bronchial asthma. And third, prolonged exposure to non-degradable toxic materials. Examples are materials such as inhalation of silica, which can induce a chronic inflammation in the lung called silicosis, and inhalation of asbestos, causing asbestosis in the lung, or in materials such as lipids or cholesterol crystals, causing atherosclerosis. The morphologic patterns of chronic inflammation are variable and include the followings. First, a chronic ulcer, such as chronic peptic ulcer. So, ulcer is a morphologic pattern of both acute and chronic inflammations. There is acute ulcer and chronic ulcer. Second, discharging sinus, as in the tuberculosis of cervical lymph nodes, with discharging tuberculous sinus in the neck, which discharges caseous material, or a chronic osteomyelitis, which is a chronic inflammation of the bone with discharging sinus opened to the skin, which discharges pus material. So, sinus is defined as a tract connects between the body surface or skin and underlying tissue or underlying organ. Sinus has one end is opened to the skin and other end is blind or closed with discharging material. Third, fistula formation, such as a perianal fistula. And fistula is defined as an abnormal tract connects between a hollow or tubular organ and the body surface or skin, or connects between two or tubular organs, and both ends of fistula are opened. Fourth, diffuse thickening of the wall of a hollow or tubular organ, such as chronic cholecystitis, in which there is diffuse fibrous thickening of the wall of the gallbladder. Fifth, chronic abscess. So, abscess is a morphologic pattern of both acute and chronic inflammation. There is acute abscess and chronic abscess. Sometimes chronic inflammation has mixed acute and chronic inflammatory cell infiltration, means mixtures of neutrophils, lymphocytes, macrophages, and plasma cells. Such inflammation is called acute or chronic inflammation, as in the osteomyelitis. Sixth, stenosis and structure formation hollow or tubular organ due to the healing by fibrosis. And the last morphologic pattern of chronic inflammation is granuloma formation. This is the gross morphology of a chronic ulcer, which is a chronic duodenal ulcer, in which there is a local defect in the mucosa or in the wall of the duodenum, which is a chronic duodenal ulcer. This is the gross morphology of a chronic gastric ulcer, causing perforation of gastric wall. This is amputated lower limb of diabetic patient due to a chronic diabetic ulcer in the lower leg, and also there is a gangrenous diabetic foot. This is a gross morphology of a chronic diabetic ulcer in the sole or foot of the diabetic patient. This picture shows the gross morphology of chronic cholecystitis. This gallbladder is filled by numerous stones with diffuse fibrous thickening of gallbladder wall. This is a gross morphology of the abdominal wall sinus. The sinus is defined as an abnormal tract, connects between the skin or body surface and underlying tissue or organ. In this picture, the sinus connects between the abdominal skin or abdominal surface and underlying small bowel in Crohn's disease, with discharging small bowel content into the surface of the abdominal wall. This is lung with tuberculosis or TB of the lung tissue and hilar lymph nodes that have granuloma formation, which appears in the center of the picture. The types of cells in chronic inflammation. As we said, in chronic inflammation, the chronic inflammatory cell infiltrates are polymorphic, means multiple cell types, including lymphocytes, macrophages, plasma cells, and other types of cells. And these chronic inflammatory cells are mononuclear cells, have single nuclei. First, lymphocytes. Lymphocytes are the main cells in chronic inflammation, and they are of two types, T lymphocyte and B lymphocytes, which are the cells of immune system. T lymphocytes are responsible for cell-mediated immunity, and B lymphocytes are responsible for humoral immunity, means produce immunoglobulins or antibodies. Activated T lymphocytes produce cytokines such as interleukins and interferon gamma. And interferon gamma causes activation of macrophages and fibroblasts in a chronic inflammation. Second, macrophages. Macrophages are also dominant cells of chronic inflammation. They are derived from circulating monocytes, and they are activated by interleukins, tumor necrosis factor, endotoxin, and interferon gamma, and become actively phagocytic cells. Macrophages, or called tissue histiocytes, are normally present as free tissue histiocytes or macrophages, such as diffusely scattered in pleura, peritoneum, and loess tissue, or as fixed tissue histiocytes or macrophages, such as in the sinusoids of the liver, where they are called Kupffer cells, in spleen, bone marrow, and lymph nodes, where they are called sinus histiocytes. In the bones, they are called osteoclasts. In the brain, they are called microglial cells. And in the lungs, they are called alveolar macrophages. The functions of macrophages. First, phagocytosis, which is the most important function of the macrophages. Macrophages are the most important phagocytes in the inflammation, and more powerful phagocytic cells than neutrophils. Second, secretion of inflammatory mediators, such as lysosomal enzymes or proteases, nitric oxide, and oxygen-free radicals, cytokines, vascular permeability factor, chemotactic factor, endogenous pyrogen causes fever, and they secrete growth factors that stimulate fibroblast proliferation and collagen production, causing fibrosis and promote angiogenesis. And third, antigen processing, by preparing the antigens to immune system to induce immune stimulation. So, the functions of macrophages in chronic inflammation differ from their functions in acute inflammation. In acute inflammation, macrophages appear after 24 to 48 hours as more powerful scavenger cells, and they are responsible for clearance of necrotic tissue and cellular debris that caused by neutrophils by process of phagocytosis. Then macrophages die and they are removed by lymphatic drainage. While in chronic inflammation, macrophage accumulation persists. They are responsible to kill the microorganisms by releasing of inflammatory mediators such as lysosomal enzymes, nitric oxide, and oxygen-free radicals or reactive oxygen species. also induce tissue damage by these inflammatory mediators, and macrophages induce tissue repair and healing by fibrosis with the scar formation in the chronic inflammation. This picture shows the morphology of main chronic inflammatory cells, which are lymphocytes and macrophages or histiocytes that are mononuclear cells. On the left is lymphocyte, which is a rounded cell, has uniform round dark staining or hyperchromatic nucleus with scant basophilic cytoplasm that does not appear in tissue section. On the right is monocyte or macrophage or histiocyte, which is large cell, has irregular or kidney-shaped or bean-shaped nucleus and abundant cytoplasm containing phagocytized or engulfed particles. Plasma cells are the third important chronic inflammatory cells, which are developed from B lymphocytes, and they secrete or produce antibodies directed against antigens. Plasma cell has a round eccentric or peripheral nucleus with granular chromatin and cartwheel distribution and abundant bluish cytoplasm. Other chronic inflammatory cells are eosinophils and mast cells. Eosinophils are common in parasitic infections and allergic conditions. They secrete major basic protein, which is toxic to parasites and also causes tissue necrosis. Eosinophil has a bilobed nucleus with abundant eosinophilic cytoplasm containing eosinophilic granules. Mast cells are common in allergic reactions and anaphylactic shock. They are inflammatory cells of both acute and chronic inflammation. In acute inflammation, mast cells release or secrete histamine that causes vascular changes, while in chronic inflammation, mast cells secrete cytokines such as tumor necrosis factor and chemokines. Thank you for your listening.